Good evening, everyone. All right. Thank you for joining the class on time, and I hope you all have watched the previous one, the first one. It was easy and light, I guess, but this one is going to be a bit intense, bad, boring, perhaps, but I've tried my best to make it like exciting and to have some fun. And get ready to be confused. All right. So let's start the meeting now. Just a quick check. In the first class, we defined two important terms. One is an axis and the other one is an angle of something. So can you tell me on the chat, what are these terms? Yeah, exactly. So we discussed together the visual axis and the angle of strabismus. And now I shall start the class by a quiz as usual. So I'm going to show you an illustration and you will find question mark. So you have to tell me on the chat, what does this question mark refer to? You don't have timers, so take your time and answer. Maybe someone intentionally give me a wrong answer because we can learn better from correcting our mistakes, you know? Finally, I got a wrong answer. Actually, my aim for this quiz is to have a wrong answer. Okay. So again, this is relevant in the exam, and I will tell you why. Definitely, this is not their visual axis. Sometimes your mind is fully occupied by some topics. Someone told you before the exam that there's going to be a case about something. You have to study this topic very importantly. You know, your mind is only blocked or like, as I said, fully occupied by this topic. And in the exam, you diagnose the case wrongly, despite being easy case, because your mind is only thinking about one diagnosis, okay? And this happened actually last year. I was doing classes about Duane syndrome, okay? You know Duane syndrome, narrowing of the fissure on adduction and some limitation on abduction, you know, is type 1. So one of the candidates actually got a case in the ocular motility station. Actually, it was an easy case because it is an accommodation esotropia. So the patient has like esotropia, and with glasses, the angle marvelously corrected by the glasses by hyperopic correction. So it's an easy case. But during her examination, she noticed some narrowing of the fissure on adduction, and she noticed also limitation on abduction, subtle limitation of abduction. So first, she diagnosed the case as Duane, but then she corrected herself later on and she passed the exam, by the way, the first attempt. But because her mind was like fully occupied by Duane, she thought the case was a Duane. But note that sometimes narrowing of the fissure on adduction, sometimes it's a normal variant. If you examine your family members, for instance, you will find some narrowing of the fissure on adduction. And because the case has like a long-standing esotropia because of accommodation, and perhaps she got the glasses later on in life, there might be some limitation on subtle limitation, mild limitation in abduction. Sometimes in infantile esotropia and accommodative esotropia, you can't see the full abduction, all right? So again, this happens right now because you all have watched the previous class. Your mind was fully occupied by my saying the visual axes are parallel to each other when you are looking at distance. And then in this diagram, you saw two lines parallel to each other. Your eyes were blocked that these lines are not passing through the fovea. And by definition, you know that the visual axis normally should pass through the fovea, okay? And I'm 100% sure that you know about the anatomical axis. Someone said pupillary axis, almost the same. So this actually not, these lines are not the visual axis. These are the anatomical axis, or you can say geometric axis, or optical axis, or broadly we can say pupillary axis, anatomically pupillary axis, okay? So again, think carefully before you answer and don't underestimate any question. Sometimes we answer wrongly despite the question being easy, okay? It was just a trick, and some of you, fortunately or unfortunately, fell in my trap. All right? Okay. So in the previous class, we discussed the visual axis and the angle of strabismus, and in today's class, we're going to talk about the anatomical axis. I already mentioned the anatomical axis is simply it's a line, line bisecting the globe. The globe is centered around this line. And we will define something very important, which is called angle kappa, okay? Because it has a lot of applications. Again, this is like a kind of warm-up slides before we start actually the class, because this class is going to be locked at some point. So I want to make sure that everyone know about Hirschberg's test quickly. So I'm going to show you this video. Just observe the video. In this video, I'm demonstrating the Hirschberg test, how we can do the Hirschberg test. I probably let you watch it twice. So remember, early on in our life, we learn by observation before even our ability to speak and to communicate when we were kids. You can learn a lot by just observing. And there is a lot of fellowships over there where you will be like only observer. So being a good observant is actually one of the character of a good doctor, okay? So once more, try to observe carefully how I'm doing the test. Okay, so Hirschberg test, we can say Hirschberg test, or we can say Hirschberg corneal light reflex, or we can say for short Hirschberg reflex. In one of my classes, I told you that corneal reflex alone might be confusing to the listener. Okay, this is like my point of view. Since we have something also called corneal reflex when we are testing the corneal sensation. But according to the context, definitely the listener will understand which test you are talking about. So right now, if we are talking about strabismus and motility, whenever I say corneal reflex, this is quite understandable that I'm talking about corneal reflection or corneal reflection test or Hirschberg test. But suppose we are talking about trigeminal nerve assessment, and when I say corneal reflex here, I mean corneal sensitivity, okay? So it's okay to say corneal reflex because the listener will understand according to the context, okay? But for academic writing, for research, when we are talking about Hirschberg test, you have to say corneal light reflex. Don't say only corneal reflex, because Hirschberg test is one of the corneal reflection tests or corneal light reflex. Okay, I was using the pen torch, and there is another fancy tool called transilluminator. This is Van Hoff transilluminator, and actually this examiner was using transilluminator to check the Hirschberg reflection. This photo was taken from Moran Eye Center, Educational Center. And by the way, this is a wonderful educational website, something called Moran Clinical Ophthalmology Resources for Education, something called Moran Core. And they have an official YouTube channel with a lot of lectures. It's something like, side-by-side lectures. They are very valuable and priceless, actually. So I want one, just raise your hand and help me to write down this slide. So I want to, write down right now with you the summary for the steps for doing the Hirschberg test correctly. Okay? So remember, in your exam, you are going to speak. So speak right now. So I make it like in a bullet, and this is the first step. So tell me the first step, please.
Yeah, the examiner sits in front of the patient at the eye level. And then with the help of the pen torch or the transilluminator, the patient is asked to look at about 60 centimeters.
Okay, so 1 second. Let's say you have to have pen torch. So I'm just writing the keywords. So pen torch, okay. And you said 60 centimeters. So, and number 3, and you said the level to be in level with the patient, okay. So like both are sitting, let's say, and you said there is instruction here. So we have an instruction, which is, can you tell me the instruction, your instruction to the patient once more?
The patient should be seated comfortably, and the patient should be looking towards the light.
Okay,
towards the light source.
So look at the pen torch or to the light. And
And we look at the corneal examiner. Examiner looks at the corneal light effects falling on the cornea.
So the corneal reflection actually is the first Purkinje image. It is it's created by the cornea, but it's located inside the anterior chamber, like in the center of the pupil. So observe the corneal reflection. Okay, so this is like the test, okay? And what is the normal finding?
Normally, the light should be well centered at the pupil, slightly nasally.
Or slightly nasal. Okay, slightly. Like in each pupil, okay, in each pupil. It's easy, right? Thank you for being very courageous, okay? So as you can see here, there is like an additional like optional point. So in order for the patient to look at the pen torch, so the patient should have vision. So here, patient should first see the light. Okay, so if you imagine like a patient with no light perception in both eyes, we can't do this Hirschberg test. Nobody would be interested to do Hirschberg test in such a patient anyway. So this is something you can do. So whenever you have like a clinical test, you can make your notes, like the key points, like summarize the points. Don't forget the instruction that should be given to the patient, because you have to give the patient proper instruction, and you have to know the normal finding, and you have to know what you are looking for, okay? And we will cover the detail about the Hirschberg test in Strabismus evaluation classes, by the way, in the other series, the more clinical practice series, okay? So in Hirschberg test, actually, it's considered as a test at near, because 60 centimeters actually is not a far object, okay? But we are trying to stay like as far as we can from the patient, because we don't need much convergence, and we don't want to cause discomfort to the patient from the light. So we usually stay like 60 centimeters or 2 feet distance from the patient's eye. But here, there is one missing key word here. There is one missing in her instruction, in her saying. So can someone point, she missed something.
Correct any head posture. The head should be straight. Primary gains.
Yeah, okay. Still one missing. Regarding the pen torch, it is, as you can see, there is like exclamation marks besides the pen torch. So can you add additional point? Yeah, someone said in the center, or we can say in the midline. The torch should be held as in the photo, like exactly in the midline.
And can I add something, ma'am? Should use the comfortable light, like yellow light, not bright white light.
Okay, so it is preferable, and this is like according to your preference. I said this once before in a previous class, because yellow is somehow more comfortable to the patient and doesn't result in after image effect. Like if you try it, if you look at the flash of your camera or any LED light, you will feel an after image like quite a few seconds after turning off the light. But the yellow one is much more comfortable to the patient. But if you don't have the yellow one, you can use, it's correct, it's okay, you can use the LED one, the white one. It's according to the examiner's preference, as I said. All right, but don't forget, this is like an important that you have to keep the pen torch, as in the photo, exactly in the center or in the midline, like midway. And as Dr. added, that the patient should be fixed, corrected, and the patient is looking straight ahead to the pen torch. Because you will see in the following slide that this is a kind of corneal reflection. If the patient is looking to another object off center, like off axis of the light source, you will get another position for the corneal reflection. Okay, the corneal reflection may be decentered because the patient is not looking at the light source.
Ma'am, can I add one thing more?
Yes, say it.
If the patient has AHP, abnormal head posture, then we should, we should observe and note it in our mind that he has AHP. But then while doing the Hirschberg test, we should correct his head and make it, so that the Hirschberg test can be done, or the point torch can be placed in the center.
Yeah, exactly. Exactly. Perfect. So you have to correct any abnormal head posture should be corrected first. You have to, align the head, and the eye should be aligned and fixate on the object. The muscle light, this is the other term for the pen torch. So muscle light is another term. So you will notice, I think, in this video that I'm gonna use my left hand to fixate to align the head. Okay, so make sure that the head is straight and the patient is looking at the pen torch, and then you will observe the cornea reflection in the center of the pupil of each eye. My volunteer is a little bit staring at light, but this is accidentally, not intentional. So again, to summarize, so we have the Hirschberg test, which is one of the corneal light reflections. We have in Strabismus another corneal light reflection test. This is called Kremesky. Some of you may be interested to know Kremesky, and we will discuss this in the Strabismus classes. Anyway, so Hirschberg test is one of the corneal light reflection tests, and it's very easy. It does need only pen torch, and it does need only patient to fixate on the light, okay? And this is one of my cases. She has like a complaint about pseudo exotropia because she got like a unique, her palpebral fissure somehow slanted. Some people told her that she might have like an exodeviation, but after like full evaluation of her ocular alignment, doing cover tests and other tests, she doesn't have any strabismus. So in order to help the patient to understand that they don't have any issue in their ocular alignment, we can photograph them using the flash of the camera, and we can teach them that since the cornea reflection is central in the pupil of each eye, this means they don't have a squint. So Hirschberg test is a good tool for educating patients, okay? But again, this is like a rough screening test for strabismus. So simply we can say if the reflection is central in each pupil, this is roughly means there is no squint at this distance and at this moment, okay? So in strabismus sheet, when we are documenting the finding, we have a space for Hirschberg test. So when we do Hirschberg test, how we can document the finding? We can write it down here right now. For documentation, sometimes needed when we are doing a test, you should know how to document the finding, okay? In documentation, you may say it's central in each eye or in each pupil, or it could be decentered. And you have to specify which eye is decentered. Is it decentered in the right eye or in the left eye, or maybe in both eyes, who knows? So which eye? And you have to say the direction. Is it decentered like nasally, temporally, okay, or superiorly? And also how much in degrees. Again, we will cover these points in strabismus evaluation classes. So when you are documenting Hirschberg test, we can say center or decenter. We don't say there is strabismus or there is no strabismus, because again, this is not 100% accurate test for assessment of strabismus. You have to keep this in mind. This is like an initial test, give you some idea, but you have to do the following tests like cover testing later on. All right. In this slide, we are going to practice some abnormality in the Hirschberg test, like how the Hirschberg test could be decentered. And I will cherish this chance to show you an important website for strabismus training. Okay, this is called Strabismus Simulator. You can just Google it and you will find the website very easily. So if I click here, start, explore mode, start simulator. Okay, this is like an orthotropic patient. Orthotropic means there is no manifest strabismus. And you can see cornea reflection in the center of the pupil of each eye, okay? So here, if I make a kind of manifest strabismus. The other name for manifest strabismus is tropia. Tropia. This is like the suffix, the end, but the prefix, the beginning could be exotropia. So if I now, so you know, I always make the abnormal eye the left eye. So if I'm making right now the left eye exotropic, the Hirschberg reflex is decentered nasally. Okay, this is a quick summary, so a quick like review. The squint, the direction of the squint is against the decentration. So if the reflection is decentered nasally, as right now, this means this left eye is exotropic. Okay. So more exotropia, so we'll get more decentration. Because again, this is cornea reflection test. Hirschberg depends on the position of the globe. Okay. But suppose now I'm creating an artificial esotropia in the left eye. Now the reflex is decentered temporally. Okay. See at the limbus. And like the same, if we have like hypertropia, the reflection, the decentration will be decentered inferiorly. But if we have like hypotropia in the left eye, this means there is the decentration here is superiorly. This means that this left eye is hypotropic. This is like in classic teaching. Definitely, you already know this. When the reflex is decentered nasally, this means the eye is exotropic, for example. But imagine now that the pen torch, we agree that the pen torch in Hirschberg test should be held like in the midline. And the patient should be instructed to look at the pen torch or the light from the pen torch. But suppose the patient is looking to the right, to another object, like in dextroversion, like here. The corneal reflection normally the corneal reflection will be decentered here temporally and decentered here nasally to an equal distance from the limbus or from the pupil. Okay, and if we keep the pen torch at the midline, but the patient is looking at the left, the reflection will be like this. So don't say in such photo the Hirschberg test is decentered. No, because now the patient is not looking to the light, it's looking to another object. So in order to do Hirschberg test, the patient should look at the light, like in the middle photo here. That's why it's very important and very critical to tell the patient to look at the light, because sometimes the candidate may be under stress, forgets to tell the patient about the instruction. They left the patient like stray without giving instruction, because you will get another findings if the patient is not looking at the pen torch. Okay. So again, if the patient is looking at the right and the pen torch in the middle, the reflection normally will be like this. Okay. But imagine now, because this corneal reflection test depends on the globe position. Okay, but imagine now I shifted the pen torch exactly on the right side and I asked this patient to look at the pen torch. Now we will get photo like this actress photo, this one of the celebrities, I guess. So now the patient is looking, or not the patient. So this celebrity is looking like to the right side. Her eyes are dextroverted, but the flash of the camera or the pen torch is coaxial with his eyes, like she actually looking at the light, and that's why the reflection here is central in the pupil of each eye. Okay, and this is normal. And if you are interested in drawing and you are like a kind of artist, it's very important whenever you draw a photo, you have to keep the core reflection exactly in the center of the pupil if the patient is looking like straight ahead. And if you want to make it decentered, it would be decentered exactly the right way. What I mean by this, if in one eye is decentered like temporary, like here, it should be decentered here nasally. Okay. Again, this is a kind of realistic drawing. This is not a photo. Here, the artist like draw the reflection here a little bit temporally. So here should be a little bit nasally. okay? And this is normal. This means his drawing is in perfect ocular alignment. Okay, so we finished the warm-up slides in almost like 45 minutes. And we shall start the class now because I'm gonna clock the meeting. Again, before I start the class, we have Vadi, all right? And by the way, this is you, and this is me, because today I'm gonna talk very slowly. I will repeat many things. In the next slides, I need confirmation from most of you that you got a slide, because in order to move to the next slide, you have to understand the previous slide. So I'm gonna move very slowly. And so you have to be patient. Don't look at the screen like this, okay? And this is the number one deal. Number two deal, in my illustration, or the following illustration, I will show you an illustration for the optics of looking at distance. I'm drawing the eyes for someone looking at distance. In other words, so you will not find any target in the following illustrations, okay? In order to help you to understand certain concepts regarding angle kappa. So all the following illustration, you will not find a target. And you know that for looking at distance, the visual axis should be parallel, okay? This is to help you to understand some concepts. Once you understood these concepts, the applied of these concepts will be on the Hirschberg. Now you are confused because Hirschberg test is a near test. We are looking at a target at 60 centimeters. But it's okay because it's gonna be complicated to draw my illustrations for a near object. That's why I'm making my illustration for at far. Once you're convinced by this illustration, trust me, it's correct to be applied on Hirschberg test. Okay, and this is the same if you remember when you were studying optics. Sometimes in order to prove a theory or hypothesis, we use a certain diagram. Once we convince with this theory, we apply this theory on another situations, okay? So be patient in order to be like a confident learner, hopefully. So we shall start right now. So get ready, this is the beginning of our class. So back again to this illustration. Remember, in every class, I will add some more details, okay? So here, for example, I've started to draw the orbital walls. As you can see, this is the orbital walls of each eye. The middle orbital walls are almost parallel to each other. The lateral orbital wall, as you can see, make right angle to each other. This is the right angle, okay? And I've drawn these walls in order to help you to imagine the position of the globe, okay? Again, these lines in black, so try to be familiar with my way of drawing, okay? So these two lines in black are the anatomical axis. Simply, it's line bisecting the globe. So this area is exactly similar to this area, or equal to this area, okay? This thing in yellow is the optic nerve. And the fovea is F, and this is like a foveal in star, this is the fovea, okay? And this cross is actually the nodal point in white, all right? Now I'm gonna show you the visual axis, okay? But in different way, it's slightly different from the previous class, okay? So how we can draw the visual axis? So I don't know if you can notice this yellow line, okay? So it is line should be from the object of fixation, which assumes that it is at distance, passing through the nodal point and then to the fovea, this yellow one. Because, you know, the visual axis is the line of sight, sometimes called the line of vision. And we see by light. That's why I've drawn the visual axis in yellow. But someone may say, Doctor, I'm confused now because you said the visual axes should be parallel to each other when we are looking at distance. Again, if you notice, this is like an exaggeration of the situation, because since the yellow line is very close to the anatomical axis, it's very close, we can, with assumption and approximation, consider these yellow lines as parallel to each other, okay? Remember, in optics, sometimes we do approximation, we do like assumptions. If you remember in optics, when we prove a theory, sometimes in equation, you will sign the angle. So we can, instead of sign the angle, use the angle itself, something like this. So we can like roughly consider these two lines, yellow lines, the visual axis, parallel to each other. So sometimes you can say like not 100%, but it's okay to say that the visual axis somehow coincide with the anatomical axis. But actually, if we like discuss in details, there is a subtle angle between the two lines. Okay, there is subtle angle. So let's try to magnify this. So I'm taking this area and I'm gonna magnify this area. Okay. So again, my first assumption, you can somehow assume that the visual axes are parallel to each other because they are like very close to the anatomical axis, okay? In order to discuss angle kappa, let's enlarge this area. You will find a space between the two lines, okay? And this angle, we can call it roughly angle kappa, okay? And the normal angle kappa is something around, it's not exact, maybe not exact 5, but something around. It could be a little bit higher, it should be a little bit lower than 5 degrees, okay? And it should be positive. So if I ask you what's the normal angle kappa, don't say 5, okay? So you have to say positive 5 degrees, and you have to say the notation. So your answer should be at least consist of 3 words. Positive, around 5, and degrees. This is a notation, degrees, okay? So someone may ask, what's the meaning of positive? In optics, positive he means that the visual axis, you see the visual axis here in yellow, cuts the anatomical axis on the nasal side, here. So again, when the visual axis cuts the optical axis in this area, because the relation reverses backward here. But here, in this area, when the visual axis cuts the anatomical axis on the nasal side, we call this angle a positive angle. Okay, this is the meaning of positive angle. All right. If we are right now teaching optics, actually this angle is called the angle alpha. But since the proximity between the term of angle alpha and angle kappa, we can use them interchangeably. But most of the clinical books you have, you will find the angle kappa. Okay, but in my illustration, actually this is angle alpha, not angle kappa. But it's okay to use them interchangeably right now. Okay, because we are not teaching optics. To summarize this slide once more, the anatomical axis is in black, aligned bisecting the globe equally. And we have a visual axis in yellow. Okay. It should pass here until the fovea. This visual axis cuts the anatomical axis on the nasal side. Okay. So the visual axis is on the nasal side of the anatomical axis. The angle in between is called angle kappa. And it's very small, around 5 degrees. And it is positive. Okay. It's okay right now? Shall I move to the next slide? Okay. For some people, okay, focus now. For some people, somehow the angle is a bit significant. Let's say it's 6 degrees, but it's still close to the normal, you know, in the high normal range, okay? Once more, for some people, try to imagine now the anatomical axis should be like exact like this, like as I drawn right now, or as I have drawn like in this slide. So it's the anatomical axis should be like this. For some people, the angle is a little bit on the high normal, like 6 degrees. So I think you can appreciate now the visual axis now is somehow directed nasally. So on this slide, I couldn't make my assumption and I couldn't say the visual axes are parallel, because this is definitely this yellow line and this yellow line definitely are not parallel to each other. Okay. So what happens reflexly in your eyes without your conscious awareness? Because normally the visual axis should be parallel from the previous class, this. But in this situation, the visual axis, because this patient has a little bit higher angle kappa, but because of this, the visual axes are not parallel. So what shall happen? So observe the next slide, because the next slide will be animated, okay? So each eye will rotate a little bit outwards, okay? In order to make the yellow visual axis like exact, like parallel with each other. So imagine now if the left eye move a little bit out and the right eye move a little bit out, as in the following slide. See now, with this kind of rotation outward, now the visual axes are parallel to each other. And this is normal, because this rotation happened in order to make the visual axes parallel to each other, which is the normal direction of visual axes when looking at distance. Okay? So I will repeat this slide once more. For some people, they have a little bit higher angle kappa. As a result, the visual axes are not parallel to each other. So each eye will reflexively shall move a little bit outward in order to keep the visual axes parallel to each other, which is the normal ocular alignment at distance. Doctor, how we can apply this? We can apply this. Remember when Dr. Rishma said the corneal reflection is central in the pupil or slightly nasally. Why slightly nasally is considered the normal? Because actually it is slightly nasally because each eye is rotated a little bit outward. And if you remember, when the eye is a little bit moved outward, the corneal reflection is decentered a little bit nasally. In this photo, if you encircle the center of each pupil and make a cross, you will see the reflection is slightly nasally in each pupil, and it is considered normal. So once more, this piece of information. You always read this in your books, that the corneal reflection normally in Hirschberg could be slightly decentered nasally. Why it is decentered slightly nasally? Because actually each eye rotated a little bit outward. And if you remember the first slides in this presentation, the decentration is opposite to the direction of the movement. Doctor, can we consider this as a squint? No, because the eye moves in order to keep the normal direction of visual axis. Okay? Again, my illustration at distance, but the concept is true also for near, as in Hirschberg test. Is it okay? So it's okay to have slight nasal decentration of the corneal reflection, and this illustration hopefully helps you to understand this. Okay, so as you can see, I have drawn here two arrows because now the visual axes are parallel to each other. Okay, let's see an exaggeration of the normal. And when we have an exaggeration of the normal, it is considered abnormal. So in this illustration, the angle kappa is way bigger than 5 degrees. This is an abnormal. This is an abnormal angle kappa. Okay, you see the distance between the yellow visual axis and the anatomical black line is much bigger than normal. Okay, and I'm going to show you what are the causes later on about abnormal large positive angle kappa. So still the visual axis here cuts the anatomical axis on the nasal side. It's positive. That's good. But it's bigger or higher, much higher than the normal 5 degrees. It's maybe like 7 degrees, okay? Or let's say 8 degrees. So the visual axes here are like almost converging. This is not normal. This is not normal for visual axis alignment at distance. So what will happen? In order for the patient to see by the fovea of each eye, each eye will rotate it outward, but to a much greater extent. Okay? Now the visual axes are perfect, aligned, parallel to each other. The applied is the Hirschberg test in this child. The photo I posted from the slide Atlas of Ophthalmology, by the way, this is the reference. So this child, the corneal reflection in Hirschberg is decentered nasally in each eye. But this is not normal. This is like an exaggerated nasal decentration because this child has an abnormally large positive angle kappa. Why there is much decentration? Because each eye rotated outward to a greater extent in order to keep the visual axis parallel, which is the normal ocular alignment at distance. And again, this is the normal ocular alignment for this child at Hirschberg test. And this child, by the way, if you do cover testing and so on, because you need to do cover test, you will find negative results because this child doesn't have any strabismus, but this is a kind of pseudo strabismus, pseudo divergent squint, pseudo exotropia. So back again to the previous slide, but now focus on the globe and on the eyes here. Okay, focus on this area. So in order to make the visual axes parallel to each other, look for the animation in this area. So the next slide, each eye moves outward, and since the corneal reflection depends on globe position, since the eye moves outward, the corneal reflection will be decentered nasally, giving the child a pseudo divergent deviation. This is from the book, but I would advise you to say pseudo exotropia. Okay, so the child with large positive angle kappa. Okay, and this is one of my patients. So here, this child has an abnormal angle kappa, like positive large angle kappa in each eye, but sometimes it's only in one eye, as in this child. So this child has a central corneal reflection in one eye, but an abnormal angle kappa in the other eye. Okay, so it could be unilateral. So this child, after doing the full evaluation, I found that he has like a abnormal large positive angle kappa, and you can appreciate that the decentration of the reflection nasally to much degree. Okay. So what are the causes that can cause abnormal large positive angle kappa? What is the angle kappa? So this is like the right eye. So this is the nasal. This is the nasal side. This is the nose here. Okay. So here the visual axis cuts the anatomical axis on the nasal side. Okay. What can enlarge the angle kappa? One cause is the fovea like shifted temporally by scarring here, like temporal scarring, making traction on the fovea. Okay, so this could be a cause. See the next, so suppose this is like the normal angle kappa. So imagine this is the normal angle kappa. If we have like the scar here dragging the fovea temporally, the angle kappa is gonna be bigger. See the animation, once more the animation. Suppose this is an normal angle kappa, and then we have a scar here. See the next animation. If the fovea is dragged temporally, okay, the angle will be bigger, all right? So my question to you, what are the causes of temporal dragging of the macula? This is an important question.
Any retinal disease which can cause drag macula temporarily. Common is retinopathy of prematurity.
Okay, thank you. My question was about what are the causes of temporal dragging, and you mentioned only one cause. So one cause, sometimes one cause is not enough. So sometimes the examiner will ask you a question like the causes, the complications, and the examiner actually in his answer key, there is a number of points. So if you just mention one point, your score is getting to be lower, okay? So temporal dragging of the macula, an important title, or you have a number of causes, okay? Again, we are learning together, so I'm talking in general because I am making the same mistakes, by the way, because I am a student in another discipline. So I'm maybe your teacher right now, but I am a student in another discipline, okay? So I'm doing these mistakes as well. I may give the examiner incorrect answer, incomplete answer, non-relevant answer. So we all make these mistakes. So, and then you said retinopathy of prematurity. And again, ROP is a big topic with different stages, with different types. You have to be more specific, which so can like what type of ROP that can cause temporal dragging? Because sometimes we have like, you know, the early stages, active ROP. So here we are not talking about active ROP. We are talking about, for example, cicatricial ROP, like inactive one, in an adult. That's why here in my slide, I said ROP, and in between brackets, you have to say cicatricial ROP. Because, you know, one of the past experience, one candidate got a case of cicatricial ROP in an adult in the posterior segment station. And the candidate was telling the examiner about the differential diagnosis of temporal drag of the macula and the scarring in the temporal retina, but the candidate didn't mention anything about cicatricial ROP. The examiner pointed out, the examiner told the candidate, have you asked the patient about a history of ROP? So the examiner was giving the candidate a hint. Then the candidate said, yeah, cicatricial ROP can result also in temporal dragging. So again, when we have ROP, it doesn't affect the life expectancy. So you may have a patient, like an adult patient with the sequela of ROP, okay? Let's see another causes, toxicara and familial excessive vitreoretinopathy, exactly. And we have other things like, but in my slide, because my knowledge in posterior segment is very humble, so I just wrote 2 causes, but you have to add on because you have to mention at least 3 causes. And I intentionally wrote ROP and familial oxidative because this is a kind of differential diagnosis. There is like how we can differentiate both because there might be confusing. All right. So this temporal dragging of the macula, because of the dragging of the fovea, the angle kappa could be abnormally large and still positive, okay? Let's discuss now another cause for abnormal large positive angle. We have a kind of refractive error. So this is my question to you right now. Which one of refractive errors, so I'm repeating the question in order to help you to give me the specific answer. Which kind of refractive error can result in abnormal large positive angle? So see, I'm saying everything, abnormal large positive angle error. So again, I got incomplete answer. I need a complete answer. Yeah, I was waiting for a 3-word answer. So it's high axial hypermetropia or hyperopia. So hypermetropia is a kind of British, but hyperopia is a kind of American. So both are correct. So high axial hyperopia, because you know we have axial, refractive, and both, but here we are talking about high axial hyperopia. Okay, so try to be careful. By the way, don't be confused by hypermetropia. And so hypermetropia and hyperopia are synonyms, are the same. But we have something called hypertropia. So hypertropia is a squint, means hyper deviation of the eye. Okay. All right. So now let's discuss how can high axial hyperopia result in abnormal large positive angle kappa. Suppose this is the normal, and again this is the right eye, and this is here the nasal, because you know the optic nerve is here, is nasal, always nasal. So normally in the average axial lens, in an average emmetropic eye, generally speaking, the anatomical axis here is somewhere between the optic nerve and the fovea. Okay, this is on average axial lens. And the yellow one is the visual axis, as I said. So suppose this is the normal, this is the average axial lens. In order to understand how can high axial hyperopia or how can axial emmetropia can result in change in the angle kappa, I have to give you numbers. Okay. So in order to give you a number, we have to agree on something. So this area is considered as the nasal retina. Okay, this is the nasal retina. Imagine that I'm giving the nasal retina a circumference of 5. I'm not saying any notation because this is just an empirical number. Okay, so imagine that the nasal retina is about 5, and then we have this area between the optic nerve and fovea, and you know it's called, we can call it
papillomacular bundle, or we can say papillomacular area.
Okay, this is one in green, and I give it number 2, like it's equal to, like dimension. This is like a dimension. And then we have the temporal retina, and I'm giving it a dimension of 5. Okay, so try to memorize these examples. So the nasal retina dimension is 5, the temporal is 5, and the
Papillomacular area
is 2. Okay, so what are the benefits of these? I will tell you in a moment. Let's see first this animation. So now focus on the angle kappa and the globe. So the globe is in this size and the angle kappa in this size. So see the next animation. Definitely the globe is getting smaller and the angle is getting bigger. So maybe some of you may say you are deceiving us by this animation. How can the angle becomes bigger with axial high hyperopia? So back again to show you the animation. This is the average globe, and this is the angle kappa. And here the eye is getting smaller, but the angle is getting bigger. So how can I prove that my animation is correct? Let's say numbers again. Okay, when we have an high high axial hyperopia, the numbers definitely are getting smaller. Okay, so remember the nasal retina was 5, so now it's becoming 4. Okay, so there is a reduction by 1. Okay, and again, generally speaking, the
papillomacular area
is almost remains constant, because when we have a change in the axial lens, the changes are more pronounced. The changes are more pronounced in the temporal retina, minimal in the nasal retina, and almost the same in the
papillomacular area.
So again, the nasal retina was 5, now it's lower, becomes 4. The
Papillomacular area
almost remains the same, so it is still 2. Most changes in axial lens, in axial emmetropia happens actually in the temporal retina. So if you remember, the temporal retina was 5, now it's becoming 2. Okay, let's add together the number 4, 2, and 2. So we have 8. So if we draw the anatomical axis, which bisecting the globe, it should be like 4 here and 4 here. Okay, so if you notice right now, the anatomical axis is becoming closer to the optic nerve. So back again to the normal eye. If you remember here in normal eye, the anatomical axis is somewhere between the optic nerve and the fovea. But in high axial hyperopia, the optic axis is becoming closer to the optic nerve and definitely will result in large angle kappa. So let's see the animation again and the number. So the angle kappa is getting bigger in high axial hyperopia because the optic axis or the anatomical axis is coming closer to the optic nerve. Let's put the two photos together for comparison. So this is the average globe, and this is the average normal angle kappa, and this is in high axial hyperopia. And you have to say axial, okay? Now, let's show you axial hyperopia in both eyes, in the orbits. Since we have here an abnormal large angle kappa, each eye should rotate to a greater extent outward in order to make the visual axes aligned, parallel to each other. And that's why this child actually has hyperopic refraction, high axial hyperopia. And that's why, since the eyes is rotated a little bit outer in order to keep the fovea aligned with the object of fixation, in order to keep the visual axis parallel, the corneal reflection is decentered nasally, giving a pseudo-divergent or exotropia. So I'm repeating the information right now, if you noticed. And back again to my case. This case is actually has high axial hyperopia in one eye. So this child has anisometropia. Because remember, anisometropia, if we have like low error or emmetropia in one eye, and the other eye has a significant refractive error. So this child actually has high axial hyperopia in his eye, in his right eye. It results in abnormal large angle kappa, and this leads to corneal reflection is markedly decentered nasally, giving the right eye a pseudo exotropic appearance. Okay, and if you noticed, the right eye looks bigger. Why? Because this is a plus lens. And you know from optics that plus lens magnifies. So this right eye is actually magnified by the plus lens in his spectacle. So this is another clue that the patient is wearing here a plus correction for hyperopia. All right? Okay. By the way, when we are diagnosed abnormal angle kappa, we have to do cover testing later on in order to confirm that this child has abnormal angle kappa. So because abnormal angle kappa means that the patient's eyes moved in order to make the visual axis aligned. So he doesn't have a squint. So even if you cover the left eye, this eye doesn't move because this eye is already aligned with the other eye. So if I ask you if the patient has pseudo squint due to abnormal angle kappa, if you cover the fixating the normal appearing eye, the eye with abnormal angle kappa will not move because this eye is already aligned. This eye already has no squint. Okay, this is another case, but I photographed this patient through the autorefractometer monitor. And this is the right eye, and this is the left eye. If you noticed here, the corneal reflection of the autorefractometer is slightly decentered nasally, here in the right eye and here in the left eye. Because this, again, this patient has a slightly nasal corneal reflection, and you can appreciate that he has hyperopic correction. But actually, this is before psychoplegia, but after psychoplegia, the hyperopia is getting higher, okay? So again, this is another example of maybe abnormally positive angle kappa, high abnormal or large abnormal angle kappa because of hyperopic correction, high axial hyperopia. So here, this is the summary slide that you will find, or you can find easily in any book. Okay, so let's summarize together. We have something called abnormal large positive angle kappa, which means more than 5 degrees. So the Hirschberg reflex is decentered nasally, like to a greater extent, giving a pseudo exotropia. Okay, what are the causes? High axial hyperopia and temporal dragging of the macula. All right. Let's discuss something else, which is, and you might expect this, that we have another abnormality in the angle kappa, which is called abnormally small angle kappa, but I'm not showing you abnormal small angle kappa, but I'm going to show you a negative angle kappa. So what's the meaning of negative angle kappa? So if you remember earlier on in this presentation, I said when the visual axis cuts the anatomical axis on the nasal side, this is called positive, okay? But imagine the visual axis is cutting the anatomical axis on the temporal side, and now it's called negative. And when it comes to negative angle kappa, you don't have to say small or large. Just say negative without any additional adjectives. So because being negative per se is something abnormal, okay? Once more, when we have a negative angle kappa, don't say high or large negative angle kappa. You don't need to say this. Say just negative angle kappa, okay? Because normally angle kappa is positive. So when you say negative angle kappa, this means it's something abnormal. And what is the refractive error that can result in negative angle kappa? So you already know from your studying high axial myopia. So I'm going to demonstrate how could the visual axis, which cuts the anatomical axis on the nasal side, become
On the temporal side.
in high axial myopia. Back again to our numbers. Remember, nasal retina 5, temporal retina 5,
Patullomacular area.
2. Let's see the next slide. So this is a high axial myopia. Again, what happened? The visual axis is cutting the anatomical axis on the temporal side. Now, I'm not deceiving you. I will prove my animation by numbers. But let's watch the animation again. Here, the anatomical axis is somewhere between the optic nerve and the fovea, and the fovea is on the temporal side. And here, the visual axis cuts the anatomical axis on the nasal side. The eye is getting bigger. What happened? The optic axis is becoming temporal to the fovea. Why? So let's see numbers. We agree that in high axial myopia, the number should get higher, okay? So if you remember, the nasal retina was 5 in average eye. Now it's becoming 6 because, you know, in nasal retina, we will get subtle changes, mild changes, okay?
Patullomacular area.
Remains constant, 2. The temporal retina is getting bigger to a greater extent. Remember, most of the time, posterior staphyloma in myopic, posterior staphyloma is usually on the temporal retina, okay? So the 5 becomes 10. Again, nasal retina 5 becomes 6. Temporal retina becomes 10.
Patullomacular area.
Remains the same. Now let's add the numbers, 6, 2, and 10. So we have 18, like the width. What's the half of 18 is 9. So we have here 6, and we have here 2, and we have here 1. So this is the anatomical axis. So let's add the numbers. So this is 6, this is 2, and this is 10. So the total will be 18. So in order to draw the anatomical axis, we divide the circumference by 2. So we will get 9. Because I want to make the center of the globe. So here 6 and here 2. So this is 8. And here we have like 1. Here we have 1. So now the anatomical axis is bisecting the globe. Because here we have 9. And here we have 9. So the anatomical axis is becoming actually temporal to the fovea. So if you imagine now the visual axis, this is the visual axis in yellow, cuts the anatomical axis on the temporal side. And since the visual axis cuts the anatomical side on the temporal side, this is called negative angle kappa, which happens in extreme degrees of high axial myopia. And these are the two photos for comparison. This is the average lens, and this is the high axial myopia. Remember, here, this is the right eye. So here the visual axis cuts the optic axis in the nasal side, but here on the temporal side, we have negative angle kappa.
Now let's see this example in both eyes. Now here is the negative angle kappa in the right eye and here in the left eye. And as you can see, the visual axis cuts the anatomical axis on the temporal side. In order to keep normal ocular alignment at distance, which is parallelism, so the visual axes should be parallel to each other. Imagine that each eye will rotate inward. So this eye will rotate inward and this eye will rotate inward. Now see the next animation. Now the visual axes are parallel to each other to keep normal ocular alignment at distance. All right. And since you know when each eye is relatively inward, the corneal reflection, the Hirschberg test, if we try to apply this example on Hirschberg test, so the Hirschberg test in each eye shows decentration nasally, giving the patient a pseudo-esotropic appearance. So that's why we always say in high axial myopia, we can get negative angle kappa, which gives the patient a pseudo-esotropic appearance. But this is not a squint because the visual axes are parallel to each other at distance. And since the concept is true at distance, we can apply it on a near testing like in Hirschberg test. All right.
And this is the summary. So we have something called negative angle kappa, which happens in high axial myopia when the visual axis cuts the anatomical axis on the temporal side. So the Hirschberg reflex is decentered temporally. When the Hirschberg is decentered temporally, gives us a pseudo-esotropia. Okay. So in high axial myopia, actually, I didn't choose this illustration, but actually in high axial myopia, the angle kappa could be positive, but smaller degree than five than the normal, and it could be getting smaller according to the degree of axial myopia, and it getting smaller until it might become negative, as I've shown you in the slide, in the previous slide. This is perhaps the final slide where I summarize the findings of axial ametropia and angle kappa changes. So this is like the last slide that need your attention. So again, imagine this is the right eye, because this is the nasal side and this is the optic nerve. Here OA means optical axis. Optical axis, the other name is anatomical axis, which is bisecting the globe exactly in black. Here's the line in black. And VA means the visual axis, and EM means the emmetropic eye. Okay, so the visual axis is cutting the anatomical axis on the nasal side, creating a positive angle kappa, which is around 5 degrees. Okay, and normally the anatomical axis is somewhere between the optic nerve and the fovea. In axial, high axial hyperopia, in green, as you can see, the optic axis is coming closer to the optic nerve. So, and remember the distance between the optic nerve and fovea remains constant. So if we draw the visual axis for hyperope, you will give a high positive, abnormally high, or abnormally large is better word. So abnormally large positive angle kappa. And if we show you the high axial myopia, see the optic axis in high axial myopia is becoming now temporal to the fovea. So if we show you the visual axis of myopia, it cuts the anatomical axis on the temporal side, giving us a negative angle kappa. The final slide from the American Academy, actually it's from Marshall Park's book. Generally find this illustration in most books. But I think it doesn't help you to imagine or to understand why we have like decentered reflex nasally and temporally, and why there is pseudo appearance. Again, if we have decentration to the nasal side, this is called positive. If we have a temporal decentration, it's called negative angle kappa. Okay. There is a subtle difference between the anatomical axis and pupillary axis. So actually, the angle kappa is the angle between the visual axis and the pupillary axis. But again, this is not an optics teaching, and I'm not going to tell you what's the difference between a pupillary axis and anatomical axis because this is not our scope. This is the question I posted, fill in the gaps. So this is a summary. High axial myopia causes pseudo-esotropia due to negative angle kappa, where the Hirschberg test is decentered temporally, and high axial hyperopia causing pseudo-exotropia due to large positive angle kappa, where the Hirschberg reflex is decentered nasally. By the time, you don't need to memorize these things because it will come naturally. Because you all know that myopia can lead to true exotropia. So myopia, high axial myopia, can lead to true exotropia and pseudo-esotropia. So it's easy to reverse the condition. So myopia causes true exotropia and pseudo-esotropia. Okay, and the same, hyperopia can lead to true esotropia and pseudo-exotropia. So it's easy to memorize the first keyword here. Okay, and definitely, you know, if we had a pseudo-esotropia, the reflex should be decentered temporally because the decentration is opposite to the deviation. So the decentration temporally means it gives us an ET or pseudo-ET appearance. Okay, and again, in exotropia, the decentration should be nasally. So it's easy again to memorize the last keyword here in this question, nasally and temporally. How about the angle itself? So myopia, being myopic is something negative. So myopia, I'm not talking about the meaning of myopia as a refractive error, but being a myopic person means your mind is closed, it's not open-minded. So you can think that myopia is something negative. So it just helps you to remember that in high axial myopia, you may get negative angle kappa. Actually, it's abnormal small angle kappa, but the higher the amount of myopia, it's getting smaller, and finally becomes negative. But hyperopia, you can imagine that hyperopia is an exaggeration of the normal. So normally the angle is positive. So in hyperopia, we have an abnormally large positive angle kappa. So it's easy to memorize the answers of this question. I posted this question, as I said before, although the first replier definitely knows the answer, but she gives me incomplete answer because she didn't notice that I'm also asking about the decentration. So she told me hyperopia, positive angle kappa, pseudo-exotropia, but she didn't mention about the decentration. And again, she said hyperopia without mentioning high axial hyperopia. And she said here myopia, so you need to say high axial myopia. So avoid answering or giving like short answer, incomplete answer, or like drop by drop answer or staccato style answer. So you have to listen carefully to the question and answer it like fully, specifically, and to be relevant. Okay. This is the last part in our presentation, which is the quiz time. I'm sorry for keeping you too long, because you have to be connected with each other, because you all have the same goal, despite being of different nationalities, let's say, different cultures, but you all have the same goal. So you have to get to know each other a little bit, and breakout rooms is a good chance for this. So some of you may like or dislike each other, it's okay. But remember, you all have the same goal. What I'm going to do right now, so I'm going to divide you into groups, 4 groups. And I'm going to show you a question right now. So you need to talk with each other. So try to work together in harmony. Try to figure out what's the meaning of my question and try to have an answer. And then you have to assign one of you. So one of each room will be responsible to deliver the answer to me. Let's show you the question first. So I'm going to read the question, true or false. So this is the first part, true or false. You should tell me, is it true or false? The following statement is true or false. And you have to justify your answer. You have to tell me why you've chosen true or false. So Hirschberg test has false positive results. Okay. And once you get a message to join the room, you have to accept the invitation. All right, we all back. Let's see. Okay, I shall answer right now. So I got an answer from room 3. Okay, so let's answer it together. True or false? So I think you all agree it's true. Okay, and yeah, it's true. And justify your answer. What's the meaning of false positive results? So here I was trying to confuse you between, because we mentioned positive regarding the angle. But here, when I say a test, this is like in general. When I say a test has false positive results, what does this mean? It means that the result shows that there is a disease, but actually there is no disease. Okay, suppose you are doing like a lab investigation and it says that there is something positive in your lab, but actually you don't have any issue. So false positive results mean something you don't have an issue, but the result is positive. So Hirschberg test has false positive results, means the Hirschberg test is decentered. And you know, when the reflex is decentered means there is a squint, but actually there is no squint. Once more, Hirschberg test has false positive result. It means that the Hirschberg test show decentration, but actually there is no squint. And this happens due to abnormal angle kappa. So when we have an abnormal angle kappa, we have decentration of the reflection, but this is not due to squint. This is actually normal in order to keep the visual axis aligned. Okay? And that's why Hirschberg test is not a specific test. You will later on know that Hirschberg test has false positive results and also false negative results. What's the meaning of false negative results? Sometimes you get a case with central corner reflection, but actually the patient has a squint, but the reflex is central because of many reasons. So that's why we always say Hirschberg test is a rough screening test, and alone is not enough, okay? Because it has false positive results in abnormal angle kappa, and we have also false negative results. What's the meaning of false negative results? That it means the reflection is central, but the patient already has a problem, has a squint, okay? So by the way, what is the most common cause of pseudo-strabismus in your practice? So in general, if I ask you, because sometimes in medicine, we have to study and to learn more about the most common causes. So if I ask you, what's the most common cause of pseudo-strabismus? Maybe it depends on the area, I don't know. Let's say in my area, but also in a number of references, the most common cause of pseudo-strabismus is epicanthus faults. And in every book, when we are talking about pseudosquint, the first cause you will see epicanthus causing a pseudo-esotropia, okay? But even if you have a patient with pseudo-strabismus, pseudo-esotropia due to epicanthus, you have to do full evaluation, you have to do cover testing, because sometimes we have a pseudo component and a true component, okay? And by the way, in epicanthus, we have a central corner reflection, and we use this photo to educate parents that the patient has no issue with their eyes, okay? But of course, after doing cover testing and excluding strabismus. So we use Hirschberg test, the central corner reflection here, in order to show parents, to assure them that their baby or their child doesn't have any issue. Thank you all. This is the end of our class. And as you see, another cube is added to the previous one. I wonder how many cubes we'll have by the end of this year. So any questions regarding today's topic? Once more, if you are talking about negative angle kappa, just say negative angle kappa, abnormal negative angle kappa, or you can say negative angle kappa, because negative angle kappa is something abnormal. But if we are talking about high axial hyperopia, you have to say it can lead to abnormal large positive angle kappa, because normally the angle kappa is positive. Okay, thank you. Thank you all, and hope to see you very soon. Take care. And don't forget post-meeting reflection. Please post an important sentence you learned today and share it on WhatsApp. Bye-bye.